Assalamualaikum.
Waalaikumsalam, Dr.
Okay, have we got everyone already?
Not yet.
Not yet. So how many more should arrive?
About 5%.
Okay, I think if 5 other than let's just start first and then they can view the recording. Okay, let's begin our session with Kitab Al-Fatih. Okay, let's it's 2 more presentation, isn't it?
Yes, Doctor.
Okay. Yeah, alright, proceed. Tafadhal.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I'm Nurhaliza binti Ahmad Izain. So today I'll continue the another half of the PBS previously. Today I'll continue with my topic, which is neonatal thrombocytopenia. Next. Okay, neonatal thrombocytopenia is defined when the platelet count is less than 150,000 per microliter. I'll correct this after this. And this thrombocytopenia can be further classified according to the severity. If the platelet count range between 100,000 to 150,000 per microliter, then that is considered as mild thrombocytopenia. Moderate thrombocytopenia is when the platelet count is 50,000 to 99,000 per microliter. Okay, severe thrombocytopenia occur when the platelet count is less than 50,000 per microliter. Okay, we can also classify this neonatal thrombocytopenia based on the timing of presentation. If the onset of thrombocytopenia occur within the first 72 hours of life, then that is considered as early thrombocytopenia. If it's occur 72 hours after delivery, then that is considered as late thrombocytopenia. Next. Okay, the causes of thrombocytopenia can be classified by several different methods. One that I mentioned before. Another thing is by looking at the platelet size. When we do peripheral smear. Another thing is by actually identifying whether this neonatal thrombocytopenia is a congenital or acquired one. Okay, another thing by looking at the gestational age of the neonate, whether this neonate is a preterm or term infant, and especially in a preterm infant also we need to look at the birth weight of the child. Okay, the thing is there will be increased risk of thrombocytopenia alone when there is decreasing gestational age. Okay, another thing is by classifying according to the mechanism, whether it is increased destruction or consumptions of the platelet, or it is decreased productions of the platelet. Next. Okay, so these are the causes of neonatal thrombocytopenia that is classified according to the mechanism. As you can see that here in increased destructions or consumptions of platelet, we have immune thrombocytopenia. We have NAIT autoimmune thrombocytopenia. Both of these I will explain later. And then we have drug-induced immune thrombocytopenia. I think in hypersplenism Cass-Tabak-Merritt syndrome, we can see sequestration and trapping of the platelet. Okay, that eventually caused neonatal thrombocytopenia. In the IC thrombosis and also type 2B von Willebrand disease, we have platelet activation and consumption that eventually lead to reduced number of platelet, and the child develop neonatal thrombocytopenia. Congenital thrombocytopenia, drug-associated myelosuppression, infiltrative bone marrow disorder like leukemia, preeclampsia can cause decreased productions of platelet, and eventually child will have thrombocytopenia. Other miscellaneous causes of neonatal thrombocytopenia is infection, asphyxia, and dilution. Okay, next. Okay, so this is this algorithm I got it from Up to Date. Okay, this diagnostic evaluation centered upon a few things. The first one, we can see that this algorithm asking or approach the condition, the thrombocytopenia based on the onset of it. Okay, and next. Okay. The reason is because of why they divided according to early onset and late onset. It is because in early onset, the most typical causes is due to complication of pregnancy, like placenta insufficiency, or it could be because of the complications of delivery itself, like perinatal asphyxia. Another thing, it could be due to maternal autoantibodies like NAIT or autoimmune thrombocytopenia that I mentioned previously, and I'll go deeper after this. In a case of, whereas in late onset, it was more of a case that is um, acquired postnatally, like bacterial sepsis, necrotizing enterocolitis, DIC. And aside from that, at the lower part, you can also see that uh, that doesn't actually exclude the possibility of NAIT, maternal autoimmune disease. Another thing could be because of a congenital infection, tortuous infection, or because of thrombosis. Okay, next. Okay. Another thing is actually by looking at the severity of the thrombocytopenia, because this eventually will affect the management. In a case of mild to moderate thrombocytopenia, typically we don't need a further evaluation or intervention. Frequent monitoring is enough. But in a case of severe thrombocytopenia, that's not the case, because it need further evaluation and intervention, because a child with a severe thrombocytopenia is at risk of developing severe bleeding. Severe bleeding is like intracranial hemorrhage, pulmonary hemorrhage. Okay, next. Next is by looking at the clinical status of the child, whether this child is actually well-appearing infant or ill-appearing infant. In the case of ill-appearing infant, when they develop thrombocytopenia, the most common case, it is more of a serious systemic disease like DIC and bacterial sepsis. Okay, another thing aside from the three I mentioned before, is we also look at the history finding and also physical finding. Okay, next. Okay, in history taking wise, these are the important notes that we need to ask. Okay, in neonatal history, I mentioned before, but I identify the onsets of the neonatal thrombocytopenia. Now, the thing is based on the gestational age, and don't forget to ask the birth weight of the infants. We need to also ask history of perinatal infection, meconium aspiration syndrome, and respiratory distress syndrome or perinatal asphyxia, as this condition can cause neonatal thrombocytopenia. Okay, in maternal history, we need to know whether there is condition that can cause thrombocytopenia. Well, to be specific, what I mean by this is actually we want to know specifically if mother has an autoimmune disorder, because mother with autoimmune disorder like SLE, ITP, can cause neonatal thrombocytopenia. Another thing, history of splenectomy in mom could actually give a clue that this mother is having some underlying condition like the autoimmune disease itself. Maternal infection and drug exposure can cause neonatal thrombocytopenia also. We need to ask thorough history about pregnancy, labor, and delivery. Okay, if there is a previous history of fetal bradyarrhythmia, and then we might to ask if mother actually have SLE, because occasionally the first presentations of maternal SLE in fetal is actually a fetal heart block. Okay. If mother does not have any SLE autoimmune disease but presented with this history, we might need to do an investigation on that mother itself. Okay, another is asking abnormal fetal monitoring on neonatal resuscitation in history. For family history, ask about family history of bleeding disorder, and specifically also ask about if there's any same episode in other sibling, because let's say there is history of bleeding or in bleeding, especially intracranial hemorrhage in sibling, the child itself will have a higher risk of developing severe thrombocytopenia. Next. Okay, from physical finding, first and foremost is by looking at the clinical status of the child itself. Whether this child is ill-appeared, like poor perfusion, appear respiratory distress, tachypneic, and then or the child is well appear. Okay, next is by looking for evidence of bleeding as well as the extent of it. Um, so child with neonatal thrombocytopenia can present with mucocutaneous bleeding like petechiae, non-palpable purpura, and ecchymosis. With severe thrombocytopenia can lead to serious bleeding like intracranial hemorrhage and oozing blood from the umbilical cord, puncture site, hematemesis, melena, and also blood thin secretion. Okay, jaundice or hepatosplenomegaly of physical finding might indicate, might give a clue that this child, this neonate have congenital infection, torches. Another thing is by looking at the syndromic finding like TAR, chromosomal abnormalities. Next. So these are the presentations of the bleeding, petechiae, purpura, ecchymosis on the skin, and also mucous membrane. Another thing is not just splenomegaly, but look for hepatomegaly also. Okay. Neonatal with torches infection might also presented with hydrocephalus and blueberry muffin rash. Okay, in this black and white image, we can see that there is deformity in both of this child upper limb. When they did an X-ray, we can see that there is absence of radius. So this is actually features of thrombocytopenia absent radius syndrome. The child also typically presented with thrombocytopenia, although there are many theories behind why the child developed neonatal thrombocytopenia. It's a rare condition. Now, the thing is Kasabah-Merritt syndrome. Okay, as you can see in that picture, there is hemangioma, but Kasabah-Merritt syndrome is associated with a severe form of hemangioma. It is called as Kaposiform hemangioendothelioma. Okay, what actually happened in Kasabah-Merritt syndrome is there will be platelet sequestration and trapping in those vascular malformation. So it will shorten the platelet survival. And then not to mention that there is platelet consumption also, a platelet activation and also consumption at the background. That's why the child eventually, the child can present with thrombocytopenia. It's also a rare condition. Okay, next. Okay, speaking of neonatal alloimmune thrombocytopenia, NAIT that I mentioned before, this is under the mechanism of um, immune-mediated thrombocytopenia. Okay, what actually happened in NAIT is the fetal platelet will express a paternal antigen that typically it is human platelet antigen HPA1A. It is actually antigen that is inherited from the father side or the paternal side. And then, but the thing is, mother deem this antigen as a foreign body or foreign matter. Like, I don't recognize this thing. So, mother will produce autoantibodies, specifically anti-platelet antibodies. So this IgG can cross the placenta. When it enter the fetal circulation, it will destroy this fetal platelet that expressing the paternal antigen. So that's why the child will presented with neonatal thrombocytopenia. Okay. So at birth, the the neonatal platelet count often are less than 100,000 per microliter. Means to say like presented with a moderate thrombocytopenia. And then it will fall typically in the first few days after birth. But over 1 to 4 weeks after that, it will gradually rise. Why is that? It is because the amounts of antibody in the fetal, the amounts of the maternal autoantibodies in the fetal circulation and gradually decrease. Okay, but the thing is about this NNIT, as I mentioned before, mom only produce antibody to attack the fetal's platelet. So that's why when you do investigation, looking at the platelet parameter of a mom, her platelet range is on normal range. Okay, In a case with increased severity of thrombocytopenia, they also increase risk of intracranial hemorrhage. If we suspect this condition, then we need to do cranial ultrasound examination. Next. Okay. Diagnosing NNIT. Okay, to diagnose NNIT, we have to demonstrate that there is platelet antigen incompatibility. It can be shown either there is a detection of maternal anti-HPA, the antiplatelet antibodies in the infant circulation, or we can do genotypic study that can actually demonstrate there is HPA genotype mismatch between the infant and also mother. This algorithm I got it from up to date also, so you can see that what are the suggestive medical history that like give a clue like this child could be having NIT. So we need to do this investigation. Okay, for management of NIT, it depends on the severity of a thrombocytopenia and also risk of bleeding. So the child might need a platelet transfusion or IVIG. Okay, if there is history of NIT in a subsequent pregnancy, the disease, the effect of the disease could be severe. So that's why in subsequent pregnancy, to reduce this effect of NIT, we can give administer IVIG prenatally starting from second trimester and then continue throughout the pregnancy. Okay, next. Autoimmune thrombocytopenia. Okay, what actually happened in autoimmune thrombocytopenia is this mother already having an autoimmune disorder like SLE, ITP. So this mother already developed autoantibodies, and these autoantibodies already attacking herself. It's just when she get pregnant, these autoantibodies can travel across the placenta and enter the fetal circulation and attack the fetal platelet. Okay, so that's why the differences in this case. Okay. Yeah, so that's the differences between NIT and also autoimmune thrombocytopenia. So that's why I mentioned before in history, you need to ask whether mom herself has an autoimmune disease. Okay, but compared to NIT, incidence of intracranial hemorrhage is quite low. Okay, treatment is supportive management and as the same as NIT, platelet transfusion and also IVIG. Okay, next. Okay, for investigation, aside from the looking at the platelet count, we also need to look at the other blood parameter like HB and then total white cell count. If there's anemia in the present, either in and or neutropenia, then we might need to think about bone marrow suppression. Okay, we can also do PFS smear to look, as I mentioned before, to look at the platelet size and also. Okay, in the case of destructive or consumptive.
I don't want to say something.
Yes, doctor.
Sorry, doctor, we can't hear you.
Yeah, doctor.
It's not clear.
They have ITP. Can you hear me? Clear tak? Tak dengar?
Sekarang baru dengar. Tadi tak dengar.
Sekarang baru dengar.
Okay, so can a newborn baby have ITP?
Can a newborn baby have ITP?
Cannot.
Yes.
Usually it's very rare lah. Usually it's maternal ITP because to have ITP your immune system must be good enough to produce autoantibodies, which usually newborn babies they don't usually have. So basically ITP, if it's affect newborn babies, is basically maternal ITP. But both NAIT and also maternal ITP, both are basically maternal antibodies, kan? It's just that in maternal ITP, the antibody is against maternal antigen, maternal platelet antigen. But in NAIT, it is against paternal antigen, paternal platelet antigen. So maknanya, among the easiest investigation for you to do to differentiate between maternal ITP and also NAIT is actually just doing simple maternal FBC. If you look at mom's FBC and the platelet count in mother is normal, so it's suggests that it is very unlikely to be maternal ITP. Kan? Sebab kalau maternal ITP, you would expect mom punya platelet pun would be low lah. Kan?
Yes.
Sebab mom ada ITP. So if the child is really well, and then you see the thrombocytopenia, infective screening all negative, torch all negative. So probably it is NAIT. So if you look at your can you go back to the investigation for NAIT? Okay, for NAIT ni memang banyak investigation. Mana satu lagi? Okay, lepas. So you can do all those investigation, maternal anti-HPA, all the genotype semua. Do you know where can we do all these tests? Do you think SUSMED can do? Or HTA can do?
I think no, when you mention it that way.
There's only one lab in the whole Malaysia that can do this test. Only one lab in the whole Malaysia, private or government, which is in the National Pusat Darah Negara. So only Pusat Darah Negara can do this test. So that's a problem. And even if we send this test, it takes I think 3 months for the result to come back. Maknanya, even if it is proven to be ITP, to be NAIT, the moment we get the result, the baby's platelet is already normal, because we expect the platelet to be normal by 1 to 4 weeks kan, sebab by that time maternal antibody ni dah tak ada dah. Because the problem is maternal antibody against paternal antigen kan. So the moment the results come back, baby punya platelet dah normal dah. It's just for academic purpose, it's just for next pregnancy. So kita kena be more careful lah with next pregnancy. And because we've had, I think NAIT is quite common lah. I think we see NAIT 1 or twice every year. NAIT several months back. The thing is, to send all these tests, we need, I think, around 10 mils of blood from father, 20 to 30 mils of blood from mother, and around 10 mils of blood from the baby. And that is a lot. Can you imagine? Ambil 10 mils of blood from a 2 kilo baby. That's real lot. And can you imagine if you are the mother, kita nak ambil 20 to 30 mils of blood, kan? That's a lot of blood. And then all this blood, it needs to be, mana you tak boleh ambil lepas tu you hantar. No, it needs to be by appointment. And you need to call Pusat Darah Negara, arrange an appointment for the blood to be taken, and then you need to arrange transport immediately. From when you take the blood, the lab process the blood immediately and send the blood to Pusat Darah Negara immediately. It's all by appointment. It's very tedious. It's very difficult. It's not easy. That's the problem lah with our setting in Malaysia. But I think among the easiest assessment for you to rule out, to differentiate between NAIT and maternal ITP is just doing simple maternal FDC. So you look at kalau mother punya platelet pun low, and then suruh ONG diagnose mother lah. Mother ni apa problem dia? Is it because of PIH ke? Is it because of preeclampsia ke, platelet dia low ke? Ataupun is it because of ITP? Kalau baby pun low, most likely it is maternal ITP lah. Okay, alright, proceed.
Thank you, Dr. Investigation. Thank you, Farah. Okay, okay. For peripheral smear, okay, I mentioned before, we want to look at the platelet size and also morphology. In the case of destructive and consumptive conditions of a destructive or consumptive condition, the platelet typically appear larger, whereas in decreased platelet condition, the platelet will appear normal or smaller in size. In the IC, we need to do a coagulation study to actually confirm it, because another thing, kalau in the case of bacterial sepsis, we need to do blood culture and sensitivity. Okay, NIT, Dr. already mentioned. Okay, in a case of severe thrombocytopenia, this one platelet count less than 50,000 per microliter, there is increased risk of intracranial hemorrhage. We might need to do cranial ultrasound examination. Other than that is by doing genetic screening and also torture screening. Okay, next. Okay, for management, as I mentioned before, mild to moderate thrombocytopenia might already benefited from continuous platelet monitoring. They don't need any further intervention or evaluation. Okay, how frequent is frequent? It is depend on the gestational age of the neonates, and then as well as the postnatal age. Now the thing is the underlying or the causes of the thrombocytopenia. Like in the case of bacterial sepsis, the child might need a frequent monitoring. Okay, compared to child with a mild to moderate NAIT. Okay, it is also based on the severity of thrombocytopenia I mentioned before. And if we administer a platelet transfusion, we do platelet transfusions, of course, we want to also see the response towards the transfusion. Okay, another thing is by managing the underlying causes. Like if this child presented with bacterial sepsis, of course, we need to give antibiotic. Okay, because even we give platelet, but the underlying causes itself is not treated, then it's not bad. Okay, in a case of significant bleeding, the child might require transfusions of a blood product. Okay, platelet transfusion is given to those who are actively bleeding and also or at risk of significant bleeding. Okay, next. This algorithm, I got it from Up to Date. Okay, the thing is there is no specific guideline to use for this platelet transfusion. There is no consensus reached to actually like saying at what levels of platelet that we need to start platelet count. So it is depend on the clinical setting and also clinician judgment itself. But the thing is, okay. So we give platelet transfusion is given based on the one I mentioned before, severity of the thrombocytopenia, the mild, moderate, and also severe thrombocytopenia. Another thing is based on the at risk. Okay, for example, like severe neonates presented with severe thrombocytopenia is at risk of a severe bleeding, intracranial hemorrhage, pulmonary hemorrhage, and others. So sometimes we even without presentations of major bleeding, we already administer platelet to these neonates. Okay, so we can see that in the this first point, regardless of the platelet count, this one is moderate thrombocytopenia. But if the neonates presented with major bleeding, then we need to give platelet transfusion. Okay, another thing is in ill appearing infant and also that has a severe thrombocytopenia, we also need to give platelet transfusion. Okay, I mentioned before about preterm, the importance of knowing preterm and also term infant. In extremely preterm infant, which is either gestational age less than 28 weeks or the birth weight is less than 100,000 gram, even without the active bleeding, we can start a platelet transfusion if the baby presented with severe thrombocytopenia. So, okay, in a case of like healthy neonates without any active bleeding, we can start when the platelet count is less than 20,000 per microliter. But yeah, I think the take home message is more of like the reason why we start platelet transfusion is I mentioned before, depend on the severity of thrombocytopenia and also the risk of bleeding. Okay, sometimes of course patient with a major bleeding, you give a platelet transfusion actually to stop the bleeding also. Another thing is in the case of severe thrombocytopenia, even without the major bleeding, we give to actually like inhibit the bleeding from actually occurring. Sometimes that's why they are given prophylaxis platelet transfusion. Yeah, I think that's all.
Okay, wait, can I say something? Okay,
Yes.
why we put different levels of threshold for platelet transfusion? Because if you see here, ill infants and extreme preterm, we take as 50,000. And then for any neonates, we take as 20,000. This is even higher if you look at the guideline for ITP. ITP, we take lower threshold for transfusion. But this one, why do we take it a bit higher and different? Is because the risk of IVH. you know, the main risk factor for intraventricular hemorrhage, IVH, is actually prematurity. So prematurity, whatever the platelet count, is already the main risk factor for IVH. So that is why, with additional problem with thrombocytopenia for extreme premature baby, for actually some take it even premature babies, they take a bit higher cutoff point, higher threshold for before transfusion. And then the other thing is, why do we, kenapa if there's a risk of IVH, why don't we just transfuse all babies? Kenapa kita buat this cut off point? Kenapa tak all babies less than 100 kita bagi je? Why? Anyone can suggest why?
I think one is we don't want to expose the child to unnecessary immunology product, and second is we don't want to waste blood donor. I don't know.
Okay, but okay, wastage is something lah. The other reason is because we know the among the cause is actually immune mediated. Immune mediated basically is maternal antibody kan. So if you give platelet, what will happen? There will be more immunological response. So you will be more usage of platelet as well. Because we don't know the antigen, because sometimes there's cross reactivity and so on and so forth. The other is, even though we know that babies, they don't have mature enough immune response for them to produce antibody that well as term babies or older children. In newborn babies, they don't have that mature immune system, but then they can still produce some degree of immunological response. So the more we transfuse, the more immunological response that will happen in the baby itself. So if you transfuse lots of platelet, the baby can produce more antibodies as well against all the platelet. Even if you transfuse RBC, pack cell, for example, even though donor host reaction is not that common in newborn babies, because they don't have, or blood transfusion reaction in newborn babies is not that common, because they don't have the mature enough immune system to have all this immunological response. But there is some degree of immunological response to them. Even though the amount is not that much, but they do produce antibodies against all this transfusion and so on and so forth. So that is why in certain countries, for example, in European countries, in UK, for example, even for all newborn babies, for blood transfusion, they always give O negative blood group, O negative for all babies. Here in Malaysia, we cannot afford that because O negative is very, very rare. So what we do is we cross match baby's blood and maternal blood, then we transfuse with the same blood group that is compatible with both. This is what we have to do in Malaysia. But in many countries, they do give all newborn babies, they give O negative, just because to reduce the immunological response to it. So that's the reason why we, and then again, risk of infection. Any blood product, there is risk of infection. HIV, hepatitis B, hepatitis C. Can COVID be transferred by blood transfusion? All those things. Okay. All right. Fine. Next, any question to the presenter?
I have a question, Doctor.
To the presenter.
To the presenter. Okay. Mija, what is the mechanism of action of the intravenous immunoglobulin in the second pregnancy? And second question is, how does we do screening of toxoplasmosis, rubella, cytomegalovirus, and syphilis? Is it in one kit or in different?
So I already put picture for you to like study. Case child with actually any infections of torches infection can present with congenital thrombocytopenia. Okay. Regarding the IVIG, the mechanism actually okay. Macam ni dilutional ke? This IVIG is almost the same dengan macam mechanism dia. Doktor, saya cakap je berdasarkan yang saya faham ni, yang saya tahu. Okay. Dia macam IVIG, kalau kita bagi dekat GBS, IVIG ni apa yang dia akan buat adalah dia akan bind to the autoantibody. So macam tu lah yang saya faham what this IVIG, kenapa kita bagi IVIG. So because dia macam kita nak kurangkan juga the destruction yang dibawa oleh autoantibodies tu. So bila dia orang binding together, so these autoantibodies instead of
let me stop you there sebab tak berapa betul lah, sedikit ajaran sesat kat situ.
Okay, doktor.
Because immunoglobulin is antibody lah. So antibody is immunoglobulin. So immunoglobulin don't bind to antibody because they are antibody. So antibody is immunoglobulin kan. So obviously antibodies, they don't bind to antibodies, they bind to antigen. Yeah, so antibody binds to antigen. So when we give immunoglobulin, and what it does is actually it competes. It competes. So bila dia compete, so your body won't produce the extra antibody in case of autoimmune. So it will compete. So bila dia compete, and then the auto antibody mechanism tu will reduce because of the competition by the IVIG itself. And then because your body detects all those things. So sebab tu contohnya macam in case of varicella zoster, for example, kan, children yang mother dia, newborn baby yang mother dia ada chickenpox, for example. So those newborn babies kita kena bagi, selain daripada acyclovir, kita boleh bagi visit varicella zoster immunoglobulin. Basically to compete, kan? Ataupun apa for example lain, ITP lah, ITP kita boleh bagi immunoglobulin. Basically just to compete with the autoantibody process lah. Kita loadkan body with the immunoglobulin. That's the mechanism.
Thank you, doktor. Macam ni untuk screen TOS, doktor?
Presenter. Bagi dia try jawab dulu. Kalau dia ajaran sesat ni saya stop tengah-tengah ni. Presenter.
According to the disease itself, kalau macam torches ni kan toxoplasmosis and then CMV, rubella. So do a virus screening based on that diseases.
Okay lah. So basically macam ni. Dia ada several mechanism. There are several way how you screen. Okay, bila you kata torch screen, it is a screening method. Maknanya kalau you are suspecting specific disease, if you suspect rubella, if you suspect toxoplasma, you can send specific tests. But if you say you are sending torch screen, generally basically it depends on the lab. Maknanya you tak tahu disease apa, you main tembak belaka, hantar this is a panel, screening panel. So bila screening panel, dia tak boleh buat detail punya test. So biasanya dia akan buat most lab dia akan buat basically is IgG. Maknanya dia akan buat toxoplasma IgG, dia akan buat rubella IgG, dia akan buat CMV IgG, dia akan buat herpes ada HSV1, HSV2 punya IgG. Some lab dia buat syphilis sekali, tapi mainly syphilis tak. Biasa dia torch saja, dia tak ada yang ES, tak ada. Dia buat torch saja. Most lab sekarang. So toxoplasma, rubella, CMV, herpes, HSV1 and 2. So dia buat biasanya most lab dia buat IgG. The problem when you do IgG adalah, do you know whether it is maternal or fetal punya or any baby tu punya IgG? You don't know. First because you don't know whether the baby has enough adequate mature immune system to actually produce IgG. So most likely it is maternal IgG. or you don't know whether that IgG, even if it is baby punya IgG, you don't know whether is it a new infection or is it early infection. You don't know. Yes, dia ada satu test kita panggil avidity. Avidity testing ni is you test the avidity of the IgG to certain antigen. Contohnya kalau you buat toxoplasma punya IgG, you can test dia punya avidity. Avidity maknanya dia punya how strong it binds to the antigen. Kalau the avidity is very high, maknanya dia binds very strongly to the antigen, then it suggests that it is actually a long infection, the old infection. So whatever problem ada sekarang ni, it is not because of the recent toxoplasma, it's an old infection. So kalau new infection, dia punya avidity will be low. Maknanya dia macam dia bind sikit dia macam tu. But again, if you just send touch screen, so it is just a screening method. So bila you dapat, you kena think and you send specific investigation. What are specific investigation? You need to send either you send for it depends on apa lab tu punya capability lah. Certain lab ada different capability. Certain lab dia hanya boleh buat avidity. Avidity maknanya again dia test the binding capability. Ataupun dia better still you hantar untuk IgM. Because you know IgM does not actually cross placenta. Because IgG can cross placenta because dia kecil. IgM is a bigger molecule. They don't usually cross placenta. Most IgM do not cross placenta. Some IgM do cross placenta. Actually, varicella zoster IgM can cross placenta. Dengue IgM can cross placenta. But majority of maternal IgM do not cross placenta. So kalau ada baby ada IgM, it is most likely a new infection. And IgM, it shows a new infection, current infection, recent infection. Dia bukan, kalau IgG is old infection. IgM is new, recent, current infection. So you test for toxoplasma, you can send toxo IgM, rubella IgM, CMV IgM, HSV IgM, and so on and so forth. Cumanya one thing you need to remember, treating all this touch is not easy. It's damn difficult. The only one that is easy to treat is actually HSV. Because HSV you can give acyclovir. Tapi HSV can cause encephalitis, apa semua lah. Treating others is difficult. Rubella is very difficult to treat. Rubella can cause blindness. And I've seen children with congenital rubella. I've seen several children with congenital toxoplasmosis. The child became cerebral palsy and blind as well. I've seen CMV infection. All these are very difficult to treat. Because contohnya, for CMV, you need to give ganciclovir or valganciclovir. Ganciclovir is very difficult to get. Not all hospitals have ganciclovir. Our hospital don't have ganciclovir. It's very difficult to treat. It's very difficult to treat. Toxoplasma also, the treatment for toxoplasma is difficult. It's difficult. It's not available in many hospitals. Okay lah, enough rambling.
Thank you, Doctor.
Thank you, Doctor.
Alright. Yep.
Thank you, Fahim.
Okay, next.
Okay, Bismillahirrahmanirrahim.
Yang ni yang last kan?
Last, Doctor.
Last. Okay, alright, mujur.
So, insyaAllah, it will be a brief topic. My name is Nufara. I will be presenting regarding the hemorrhagic disease of newborn. Okay, next. So this is the outline. Basically, I will present regarding the causes of hemorrhage in newborn, what are the fetal coagulation system, the coagulation disorder in newborn, and how do we approach, and regarding the HDN. Okay, next. So basically, hemorrhagic disease of newborn is actually a former name for vitamin K deficiency bleeding. Now it's more known as VKDB, which is vitamin K deficiency bleeding. It is a rare complication because it is even though in physiologically neonate can be presented in vitamin K deficiency. But however, to proceed to complication or hemorrhage, it is quite rare. Okay, for infant, it is usually in history when we found out that infant who did not receive prophylactic intramuscular vitamin K will be present with this condition. Okay, next. So the causes of hemorrhage, like my friends already presented before, there's a lot of causes of hemorrhage happen in newborn, which is the first one is of course trauma. And then we have liver failure, which is the liver failure is one of the mechanisms that lead to HDN. And then we have transient vitamin K deficiency is actually the physiological condition in newborn that lead to vitamin K deficiency. I will explain later. DIC, a pathological condition of bleeding disorder, platelet disorder, like Nija represented, and also inherited permanent deficiency of coagulation factor. Okay, next. Okay, so actually what happened during birth for fetus, during birth actually or before that, the coagulation factor naturally do not pass easily from the placenta to fetus. So naturally newborn have relatively low factor 2, factor 7, factor 9 and factor 10. So this 4 factor is the vitamin K dependent. And also factor 11 and factor 12 or prekallikrein and kininogen is a part of the coagulation system are also naturally low in newborn compared to adults. So however, need to be noted that fibrinogen or other factors, platelet count are considered to be normal. So that we need to understand in this condition of vitamin K deficiency. Okay, next. So we know that vitamin K are being acquired by baby or by adult through dietary, or basically through the vitamin K that being synthesized in our intestine. So when this vitamin K will then solubilize by bile salt that's secreted by the biliary system, that allow this vitamin K, it is a lipid soluble and into a more smaller molecule and allowed to be absorbed in the intestine. So this, once it's absorbed in the intestine, it will circulate to the liver, to the portal hepatic system for a process we call gamma carboxylation of the prothrombin group. So okay, next. So what happened is, like I said just then, gamma carboxylation of the prothrombin group. So basically the prothrombin group is the 4 factor, which is the 2, 7, 9, and 10. I hope you guys can at least remember that in this topic. So 2, 7, 9, and 10 are very important factor that depends on the vitamin K availability. So we know that vitamin 7 is in the extrinsic factor, and also vitamin 2, okay wait, vitamin 2, 9 and 10 is more happen in the common pathway. So we know that it more affected at the extrinsic and also the common pathway, which is this will once we understand this, it will affect the whether APTT or PT. We know that intrinsic factor will affect the APTT more, while extrinsic or common will affect more or the PT. So once there is vitamin K deficiency, so this factor cannot play its role to undergo coagulation process, and that's why it can cause bleeding. Okay, next. So vitamin K action, other than to actually activate factor 2, 7, 9, 10 through the gamma carboxylase process in the liver, it also help in the bone malformation, which is to form the osteocalcin. So that's why sometimes it can be cause bone demineralization in vitamin K deficiency. So other than that, it also activate protein C, S, and Z, where it's actually a cofactor in the cofactor for the prothrombin group just then. So so vitamin K actually act as coenzyme of carboxylation, where this carboxylation happen in the liver. So if a neonate happen to have a liver disease, this carboxylation process cannot be done. Okay, next. So this is what I said just then. What happened in newborn? So it is said that naturally newborn sometimes can be presented as vitamin K deficiency. That's why one of the main two investigation that we did actually the PT and the coagulation profile, which is APTT and also PT. So however, it's actually different for preterm and term and also more mature infant. For preterm, it is signs to be abnormal when it is for normal value is 50 to 80 seconds. So abnormal will be more than that. For term, for normal it will be 35 to 50 seconds. So for older mature infant will be 25 to 35. So usually that APTT, it more happen in like I say, it affected by the intrinsic factor. So it usually happen when the patient have a coagulation factor coagulation factor disorder such as hemophilia. However, in a more disease, in a other disease such as liver disease, is more affected the PT. So PT in term infant, the normal range will be 13 to 20, while preterm will be 13 to 21. And also for more mature patient, it will be 12 to 14. So basically need to be noted that when the newborn have a liver disease or basically biliary system disorder, it will more affect the PT. Okay, next.
One thing to note, these numbers, they don't just differ according to the gestational age of the patient. It also differs according to the machine in the lab. Because different machines in the lab give different normal range. So you cannot just depend on the number that is in up to date or anything. You need to look at the number that is in the machine as well. Because that is why the lab will usually give the reference range, the normal reference range for the lab. So you need to think about those things as well, because the number, again, it will depend on the machine. Okay, all right.
Okay, thank you, Doctor. Okay, so basically in newborn, vitamin K deficiency type, there is a 3 type. We have a early type and classic and late. So in the first 24 hours, it is due to because when they were born, they actually born with sterile gut. So this sterile gut without the normal flora, like I say, normal flora is important for the to synthesize the vitamin K that exists in the gut. So if with the sterile gut, so that's why baby sometimes have naturally deficiency of vitamin K. So other than that, if maternal happen to take antibiotic, so it has the same mechanism to actually destroy the normal flora and then lead to sterile gut. Okay. And then we have a classic 2 to 7 days vitamin K deficiency. Late onset, 3 to 8 months, it is usually because of when it is more to predisposition of when after the birth. Okay, but before that, I will go to the causes first, where fat malabsorption can cause vitamin K deficiency due to the vitamin K is unable to being as a lipid soluble and unable to being absorbed into the intestine. So that's why when the newborn find out to have a biliary system disorder such as cholestasis or biliary atresia or cholangitis or basically intestinal tract disorders such as celiac disease that cause interrupt the absorption of vitamin K. So that's why fat malabsorption is one of the causes. So the interference of carboxylation just then, like I say, happen in hepatic disease, but and also naturally, newborn are actually born with immature liver. That's why it can cause some physiologically the vitamin K deficiency too. So number 4 is very important point for late onset vitamin K deficiency is when there is a history of refusal to take the vitamin K prophylaxis upon birth. So that's why it lead to later on the deficiency. Okay, it is also said that for breast milk, it has a lower content of vitamin K. So or lower content of vitamin K compared to formula milk. But however, even though it is according to up to date, even though with exclusive breastfeeding, it's quite rare to have vitamin K deficiency bleeding. So sometimes there's other factor that play part in the condition. Okay, and also poor oral intake of the vitamin K. So this involves more to the maternal side of when the maternal have a history of upon the dietary habits. Okay, next. Okay, so basically the risk factor for BKDP is the first one is prematurity and the breastfeeding because of the milk content. The mother drug, which is such as phenobarbital, phenytoin, warfarin, isoniazid, and rifampin. It is said that because of this drug that appear similar to the structure of the, for example, I take warfarin. Basically, this drug is similar to warfarin. It appears similar structure that of an enzyme that actually inhibit the carboxylation. That actually inhibit the oxidation of the vitamin K. So that's why if mother happen to take this kind of drugs, can lead to the inactivation of vitamin K and then lead to vitamin K deficiency. Okay, but different with antibiotic such as isoniazid or rifampin, it is more to mechanism or in towards cause the sterility of the gut. Okay, so neonatal hepatitis, biliary atresia, cystic fibrosis is caused that affect the biliary system and then cause fat malabsorption. Intestinal disease such as wheat malabsorption, such as celiac disease or IBD, that also affect the absorption of vitamin K as vitamin K are also being absorbed at a part of the a part of the distal small intestine. Okay, next. Okay, so approach to HDN. In history, we do the first important point we need to take note if there are any easy bruising, such as any in the cutaneous bleeding, or any mucosal bleeding, such as hematosis, melena, or epistasis. But sometimes we need also to take note any neurological symptoms such as seizure or vomiting because we concern of the complication of severe hemorrhage that cause the intracranial hemorrhage. Or basically any bleeding from venipuncture or heel stick site or circumcision site or umbilical cord. So this is when, because like I said that vitamin K deficiency is more effect on the common factor. So common factor or extrinsic pathway, it causes more deep bleeding, more severe bleeding compared to intrinsic pathway. That's why basically we need to take note any history of bleeding, it can predispose to HDN. So jaundice because of the biliary obstruction, or any past medical history of cystic fibrosis, biliary atresia, history of prematurity, or any antenatal history of maternal drug, or basically we want to rule out any other causes of hemorrhage, such as any maternal disease of ITP, preeclampsia, or infection. History of Okay, this is repetitive. Okay, feeding history, whether the newborn had exclusive breastfeeding, any history of coagulation factor, or the most important history will be the parenteral refusal of vitamin K prophylaxis. Okay, next.
Which is becoming more common nowadays, with all this anti-vaxxer apa semua. So we have more parents refusing vitamin K prophylaxis because they think it is vaccine. These people, they refuse vaccine. That is another issue lah. I can talk for hours because of that, about all this. They refuse vaccine. They even refuse vitamin K. It's vitamin, for God's sake. So well, people have weird things about so many things, weird ideas about so many things. Okay, all right, proceed.
Thank you, Doctor. So that's very important history. Clinical presentation, the sign of any generalized bleeding such as ecchymosis or any sign and symptom of gastrointestinal hemorrhage, and also detected any bleeding from the circumcision, umbilical style and so on. And also we need to take note the severity of the child, whether in severe hemorrhage we afraid of the sign of shock, which is we need to take note of the vital sign, if pallor and jaundice present or bruises or bleeding, and also the most and also important to take note the neurological examination as it will affect the if there any condition of intracranial bleeding. Okay, next. So investigation, full blood count for the hemoglobin and platelet level. Need to take note in HDM we do the newborn have normal platelet level actually. So liver function test for the underlying liver disease. Coagulation profile, so we know that it will vitamin K deficiency is more sensitive in terms of the PT profile. So PT profile will be more prolonged than APTT. Sometimes there's such investigation that indirectly detect the vitamin K deficiency that they do test to detect the prothrombin factor, which is 27910. And level of protein induced in vitamin K absent, or we call PIVKA2, is actually a sophisticated investigation. It is quite rare to be done, but it is said in the textbook. So it is one of the investigation that actually can also detect the vitamin K deficiency. So other investigation to rule out intracranial hemorrhage will be the CT scan, MRI of the brain or ultrasound, and also stool cord blood. Okay, next. So the treatment, actually when we found out when the newborn actually have the condition of vitamin K deficiency, one of the even an emergency or normal condition, we give the same treatment, which is the parenteral vitamin K. It is either to be given subcutaneous or intramuscular. For the condition. So while for prophylaxis vitamin K, it is said that it given to all newborn shortly 1 hour after birth, and then by monitoring of the coagulation profile, it may repeat. If it persists, it may repeat for 6 to 8 hours. And also it is said that for IV infusion of vitamin K, it need to be in a slow infusion to avoid any anaphylaxis. And for late onset vitamin K deficiency bleeding, it is recommended to give a booster for vitamin K administration. In a severe bleeding or severe life-threatening hemorrhage, it is more recommended to give fresh frozen plasma or prothrombin complex, as it has a quicker onset compared to vitamin K. Okay, I think that's all. Next, ada lagi? Okay, that's all from me. Any question?
Anyone? Any question to the presenter? Not to me, to the presenter.
Hello. Okay, I want to ask if the mother consume anti-epilepsy, for example, phenytoin, because we know phenytoin can cause has high risk to get hemorrhages of the newborn. So does the child need to take not the child. Does the mom need to take prophylaxis for NTK? Because I have read on the internet about that. I wasn't sure. Okay.
Soalan Alisha, whether the mom need to take the prophylaxis. Macam tu ke?
Yes.
Okay, so from what I read, it is the same as for the adult or any adult patient that take a warfarin, they do need to take a supplement of vitamin K. But it's what I read, they take in an oral form, oral vitamin K.
So the mother need to take vitamin K supplements only. Just confirm.
Maksudnya Alisha, macam mana?
So maksudnya kalau mak tu dia hanya perlu ambil suplemen K je lah, dia tak payah ada immunization. Betul tak Iran?
Immunization. What immunization are you thinking?
I think rasanya tersilap kot. Immunization ke suplemen lah.
What type of immunization? Vitamin K doesn't involve immunization. It's totally different thing. There's no immune response. There's no immunological response associated with vitamin K.
Saya rasa saya tersilap baca kot.
Well, there are some studies suggesting mother to take extra vitamin K supplements also. But the thing is, vitamin K is part of fat soluble, ADEK punya ni, fat soluble. So there are some suggest mother to take. But the thing is, you don't actually need vitamin K supplements. You don't need vitamin K supplements. I think there are some suggestion for mother to take some degree of supplements, but I think there's not enough evidence lah. It's not being practiced anywhere.
Okay, thank you, Doctor.
I have a question, Doctor.
Ask the presenter.
Okay. When we give vitamin K to the mother during pregnancy, secondly, how we advise or manage patient or mother who refuse vitamin K. Anyway, kalau anti-vaccine tu, we know how to advise, okay, but vitamin K, don't know. That's the question.
Presenter.
To the mother je. Saya
macam ni lah. Okay, we don't give vitamin K to mothers. We do not give vitamin K to mothers. So kalau question apa, bila kita bagi vitamin K to mothers, the answer is we don't give vitamin K to mothers. We give vitamin K to newborn babies. The moment they deliver, dia lahir, at delivery room tu kita cucuk IM vitamin K for babies, bukan for mother. Okay, there are studies suggesting supplementation of mother with vitamin K. Why? To increase vitamin K in milk, maternal milk, to increase vitamin K and so on and so forth. But the thing is, it's not evidence based enough for it to become a regular practice. We don't usually do that yet in Malaysia. So we don't supplement mothers with vitamin K. We do give newborn babies. again, issues with anti-vaccine. The issue is they don't understand what is vitamin K. They think vitamin K is vaccine. It's so totally different thing, totally different mechanism. It's vitamin. And then the other issue is how to counsel. Don't be bothered to counsel. The thing is with anti-vaxxers, they have fixed false belief. Whatever you say, they're not gonna take, and they're not gonna take it. Even if you give fatwas from Mufti, from Qaradawi, from Lajnah Daimah Saudi, from the European Fatwa Council, from the World Ulama Council, you won't affect whatever their fixed false belief. So what I'm trying to say is, for IIUM students, you need to understand the Islamic aspects of vaccination. Last year I have one lecture with the 5th year about Islamic issues related to vaccination. I hope we will have another session and we'll discuss about the Islamic issues related with vaccination. So my point is, you need to understand a bit about vaccination, about immunization, and especially with this new COVID-19 vaccine by Pfizer and Moderna, which uses a new type of vaccine, which is using mRNA, which I think is very interesting. So you just need to have an idea, and tak payah struggle too much lah about all this anti-vaxxer punya group. We just focus on those people that we can still focus and give help. If they don't want our help, then that's fine. Don't fret about it.
Okay, Doctor.
I have
Okay.
question about, I'm not sure what level just now. According to gestational age, the preterm, the term, and the other one is more mature infant. What's mean by more mature infant?
More mature infants. It is
What is infant?
Infant is 1 year old.
Infant is children less than 1 year
1
old.
year old.
So term infants are babies born at term. That's why we say term infants. More mature infants are infants that are beyond the neonatal period. They are more mature. Je.
Okay, Doctor. Thank you.
Ni presenter tak menjawab soalan ni. Sudah. Berapa markah kita nak bagi ni? Aku je menjawab soalan ni. Susah ni. Okay, alright. Any other question to the presenter? Tak ada. Clear. Faham belaka. Fahim tum. Kalamuhum.
Doktor, saya ada question.
To the presenter.
Tapi ni bukan topik ni.
Bukan topik ni.
Pasal herpes zoster tadi.
Okay.
Ada vaksin ke untuk herpes zoster, Doktor?
Tak ada.
Tak ada. Tapi saya baca kat mana? Sebab ada presentation herpes zoster. Actually, to prevent the complication of elderly to get herpes zoster complication, we give vaccine.
What vaccine?
What vaccine? Herpes zoster vaccine.
Mana ada herpes zoster vaccine?
Tak ada. Okay. Thank you, Doktor. Itu je lah.
Kalau ada pun something that I have not heard, and so far I'm not I don't think there's any herpes zoster vaccine. Oh, ada herpes zoster vaccine by okay, Okay, that's the problem. We were talking about herpes simplex tadi. Yang presentation tadi is about herpes simplex. So herpes simplex, there's no vaccine. There's no vaccine for herpes simplex. Herpes zoster ada vaccine. And the vaccine is not for herpes zoster. The vaccine is for varicella zoster. Chickenpox vaccine. So you know herpes zoster, the first time you get the virus, it becomes varicella zoster, it becomes chickenpox. If you get reinfected, you'll get herpes zoster, shingles. So the vaccine is actually varicella zoster punya apa nama vaksin lah. Zorivax ke apa nama dia macam tu. Dia ada varicella zoster vaccine, dia ada juga Verivax atau Zorivax. And then dia ada juga yang combine varicella and also apa nama MMR. So dia ada yang tu. Tapi so by giving this vaccine, it actually reduces the risk for more severe complication. The one I answered just now is actually for herpes simplex. So because yang touch tadi is herpes simplex, bukan herpes zoster.
Okay. Faham, Doktor. Thank you.
Varicella zoster. Okay, alright. Cukup lah. Okay, tak ada soalan lain I think you have another session at around 11, is it? Okay, alright. I think if that is all, let's end our session with tasbih kafarah surah Al-Asr. Okay, Assalamualaikum.
Thank you, Doktor.
Thank you.
Okay,
Thank you, Doktor.
Assalamualaikum.